5:30 at Marina Club. So people who are at hotel will not have enough time to lie down or anything, because we just want to see the sunset as well when we are going there. We go and have some drinks, and then at 7:30 we go on a boat, and that's a 2-hour tour with the dinner. We will get them to see it again, and especially somebody who is late, like Nikolay. Okay, so I think we're going to start with Mehmet, and he's going to tell us something about what happens when there is osteoporotic fractures.
Okay. I guess you will not sleep with my talk. Yeah. Yes. Osteoporotic fractures is becoming more and more problem in our daily practice. The patient population is getting older, so we are seeing more geriatric populations. So we are having osteoporosis-related problems. There are mainly 3 options. One is the conservative, the other one is the vertebroplasty or kyphoplasty, and the third one is the posterior fixation, open surgery. I will try to make some explanations about two of those things. I will not mention anything about conservative treatment. Most conservative treatments are for osteoporosis, not for osteoporotic fracture itself. But actually, not all osteoporotic fractures need an intervention, a vertebroplasty or open surgery. Keep the patient for 1 or 2 weeks in the bed, and then tell the patient to wear a brace. If he or she is not very painful, then the patient can leave without any intervention. Best rest and brace is one great option. Actually, vertebroplasty. Yes, I'm not against this. It may be. What do you think?
For last 4 years, I've been using calcitonin in every patient, and within 10 days, average, every patient's pain goes away. And it's amazing. It's intranasal they have it.
Okay.
So the last vertebroplasty I did was a couple of years ago. So I maybe do one every 2 years now, whereas before I had to do one every 15 days.
Okay. If the pain is really subsiding with anything, that's okay. It's not necessary. Actually, for the indications of vertebroplasty, it's written that the pain does not subside with conservative measures. So it may be calcitonin or bracing. But if not, in the past we were telling that only the new fractures needed vertebroplasty, but now we can also say old fractures may also need vertebroplasty. Probably most effective and most minimally invasive spine surgery is this. And this is a summary of what we say about kyphoplasty and vertebroplasty. If we compare it, the kyphoplasty's advantages are low rate of cement leakage, better technique to improve kyphotic deformity. I think it is not very necessary. We don't need to correct the deformity in most of the cases. We don't need it. Lower rate of neurologic complications. But the cons are more expensive and more radiation exposure. The possibility of cement leakage is somewhat lower with kyphoplasty. But in experienced hands, vertebroplasty have almost same results with kyphoplasty. So for juniors, it may be more suitable to use kyphoplasty than for seniors. I think I could explain this. This is the most important point here. Now I am doing no kyphoplasty at all. Just doing vertebroplasty. So it is cheaper. It is with less radiation. It has the same amount of cement I am injecting, and I have almost no complications nowadays. Vertebroplasty, the history is very old. In 1984, some person from France have described that. But however, balloon kyphoplasty started first in 1998. It's quite later. You insert a and you and create a cavity and remove the balloon afterwards, inject the cement inside that cavity which was created by the inflation of the balloon. The indications are osteopathic compressions with pain and osteolytic tumors with compression. There are some trends also to apply it in traumatic in young patients. I'm personally against this, and I have done it in a few cases, and I have got no good results, and then for trauma. Technique, general local technique, I was also doing under general anesthesia. I was scared about the technique, but now case in CR fluoroscopy, 2 CR may be better, but I don't have it. Operating table is a must. There are mainly 2 approaches. One is transpedicular approach. The other one is approach. Especially in the lumbar levels, switch to extrapedicular approach. So then I'm using now from one side, mostly left side, insertion of the cannula inside the body, trying to stay in the middle of it, and then inject from one side only. This is a case. Yes, 2 balloons were placed, and then cement was injected. This is at the end. This is a tumor-related compressions in 3 levels. The patient had got also radiotherapy at those 3 levels. And we have done 3 levels kyphoplasty and leakage inside this space. This is not a very important thing, but in case of intradiscal cement leakage, then you may expect the adjacent level compressions later. Incidence of compression of this level, upper level, is somewhat higher and if the leakage is inside the disk. So we try not to get any leakage inside the disk. Very rare condition in after birth, after a recent pregnancy, this very young lady, 21 years old, had got multiple levels osteoporotic compressions. And we did 4 or 5 levels. But in this case, calcium phosphate injection. In the young patients, young persons, I don't like to inject cement. This is the Cortos injections. You cannot see it well. It is not very radio opaque. This, and yes, Cortos. There is some leakage inside the canal, but it's not much. So then we didn't do anything. Difficulty with Cortos or calcium phosphate is it becomes solid very in a very short duration, very rapidly. But in this cement, very viscose cements, you have to wait till it becomes somewhat solid, and then you inject. However, the duration of solidification is quite fast. There are many complications of vertebroplasty and kyphoplasty. Cement leakage is the most important one. Neurologic worsening is because of cement leakage mostly. Although it is rare, it is a catastrophe then. I've seen a few cases which was done by others. The patient became suddenly paraplegic, and even a surgery and to try to remove it did not improve the patient. There are technical complications, transient increase in pain, reband sternal fractures, infection, cement embolism. I did not see any of these, but I have seen one case of infection. But in that case, I got a biopsy from the level, and then with intravenous antibiotics, it recovered. Yes, these are the pros: low rate of cement leakage, better technique to improve kyphotic deformity, and less cement leakage. However, vertebroplasty has more inexpensive, is cheaper, and less radiation exposure with vertebroplasty. Yes, these are the contraindications. If there is especially coagulopathy or some sort of infection, it's better not to do it. Yes. Further. Yes. Let's come to the posterior fixation. I'm seeing sometimes my colleagues are deciding to make open surgeries and pedicle fixation for osteoporotic fractures. It is quite rare. The indications are very unusual. Actually, in case if there is a neurologic deficit, which is very rare, I have not seen any single case with a very old person with neurologic deficit. Did you see some? Almost never. But it may happen? If there is too much kyphosis at the level, a very sharp kyphosis, if there is some neurologic deficit, you may do a open surgery. These are the indications. If there is severe kyphosis, which would develop later, not at the beginning, and if there is neurologic deficit, you can make posterior surgery. One of the wrong indications, vertebroplana. Pressure is too much, and the vertebral body is like a small line. Somebody thinks that no, it is impossible to make a vertebral press. No, it is not. You can make. You can make it. Bone fragment inside the canal is also not a contraindication. There is mostly some bone cement inside. In case there is too much bone cement inside, you must try to be as anterior as possible. And you must adjust the liquidity or viscosity of your cement. You must inject it in the last stages of solidification. Okay? What about if you are doing any fixation in case of osteoporotic spine? If there are osteoporosis, you must use screws with larger diameter. You must use longer screws, and bite cortical screwing you must try. Sometimes you can use hook and wires instead of screws, because hook or wires are attaching to the cortical bone, which cannot be distracted with a hook or wire. But the screws are inside the spongious bone and they can move. You must try to make a multiple level fixation instead of shorter levels. You can avoid tapping, because tapping and then screwing will diminish the strength of your screw. Not too much, but partially. Add cement afterwards. To do that, you can use cannulated screws or injections afterwards. And you can add anterior strut grafts sometimes. I will give you some examples. The hooks will give more resistance to back out than the screws. You can, today Nikolai has described that you can use cortical screws instead of spongious pedicle screws. So then these screws are aimed to the end plate. So then they are having too much purchase of the cortical bone instead of spongious bone. Angulation between screws is also important. By medial screwing increases back out resistance. This one is better than the upper one. There are enlarging screws like this, producing this. There are possibility of cannulated screws. You can inject some cements via cannulated screw. And 1 cc for thoracic vertebra and 1.5 cc for lumbar vertebra is enough. This is one of my cases. It was a revision case. We have done a L2 osteotomy and a long fixation, and because we were scared of having a junctional kyphosis, so then to upper levels, to healthy levels, and also around the upper screws. So I am doing recently, I find it more practical. After finishing the surgery, I place cannula and then inject cement around the screws with the cannula. This is the from C-arm of the operating theater. Okay, this is around the screw. This is health levels. 3 years follow-up, no problem. We must also avoid forceful maneuvers. If we osteopathic spine, if we make forceful maneuvers, we will have problems. In conclusion, we must avoid open surgery in osteopathic vertebral fractures, and we must avoid in every osteopathic patient's surgery. But it's possibly you will say, thank you for listening to me.
We're just going to add a talk at the end by Ovi, who is going to be talking about. Talk about how you approach the endoscopy patients from anesthesia and anesthesia, because they're always anesthesia. Oh, that's good. It depends on that. You finish early, then you get half an hour nap. If you don't, then you don't get half an hour. Okay, so the coffee. Yes, sir. Can we get coffee first? And
okay, excellent. So we have talked about lumbar and thoracic spinal surgery the last 2 days, and
take this mic so that you don't have to bend down. Just ignore that mic. Use
okay, thank you, perfect.
that.
Yeah, I need an injection later on. Facet block. Okay, so the last 2 days we talked about lumbar and thoracic spinal surgery and minimally invasive tactics. Today I would like to talk about a way how to approach the cervical spine posteriorly with the EasyGo system. I think everybody in the cadaver workshop have used it so far. Additionally, when cervical spine surgery started, any disease or disorder was approached from posteriorly, and especially in the cervical spine in the beginning there was a huge tissue dissection, subperiosteal, and patients after on they had lots of pain, muscle spasms, etc. It was a huge advantage in 1947 when Scoville developed the posterior cervical laminoforaminotomy to decompress the nerve root to treat cervical radiculopathy. But still, this required subperiosteal preparation, and frequently patients had postoperative neck pain and epidural fibrosis, recurrent radiculopathy. And then in 1955, when Smith and Robinson came up with the anterior cervical approach, these approaches sooner or later they disappeared. The posterior approach is not always bad. As I mentioned, you can expose the nerve root totally, better than in the anterior approach, but it also has some slight disadvantages. And if you remove too much bone there, it might be even spinal instability. So in 1996, when introduced the tubular retractor and published their microendoscopic discectomy, it didn't take long, about 5 years, till the first groups used exactly the system to treat cervical radiculopathy. And these are 2 reviews recently done, and they analyzed the minimally invasive, either tubular or full endoscopic posterior cervical foraminotomy compared to open or microsurgical foraminotomies. And the huge advantage in, and both reviews demonstrated that all of those patients that had less blood loss, they needed less pain medications. Depending on the country where they were operated on, they left the hospital on the same day. They had a very good aesthetic result because there was no atrophy of the posterior neck muscles. Again, if you look in the literature, you will see that there are only 24 papers out the endoscopic posterior cervical foraminotomy, and this was recently done. So the problem with those manuscripts and with those papers are that they took a lot of different diseases into one pocket. They just analyzed the surgical technique, but you have to be very, very careful if you say that a surgical technique serves best for all the diseases, because this is not true. There are differences, and we proved this regarding the underlying diagnosis. So you can see that a few groups, they operated with a full endoscopic system, a 6.9 millimeter endoscope, and others, they used, like Richard Fessler, they used a tubular retractor. So we have done a couple of studies as well, and we think that the posterior endoscopic cervical foraminotomy is ideal in patients with an bony foraminal stenosis, as you can see right here. This is a patient, he had previous cervical discectomy in 3 levels, as you can see here, but frequently it's very, very difficult to decompress the foramen anteriorly, because you have the vertebral artery. Maybe you don't get, depending on the anatomy of the patient, the correct angle to decompress it. And yeah, this patient showed up about a year or 1.5 years later with symptomatic cervical cage subsidence and when the fusion takes place. So all of our patients are operated in modified Concorde position, so the head is fixed into a Mayfield clamp. We are very careful that the head is above the heart level, but depending on the size of the patient and its shape, this might not be always possible, as you can see right here, due to a kyphotic deformity of the cervical spine, and the head is slightly inclinated. You can also operate on this. You can also perform this procedure in semi-sitting position. Because, it takes too much time to place the patient. So at next, and I can't stress this often enough, I said this already in the lumbar cases, you need to identify the level where the compression is at with your spinal tap needle. Again, it should point straight forward to the foramen, which is about here. Done this. Here you can see the needle, then you mark your skin incision. Once you did the skin incision, then you dilate, you open the fascia, you dilate to the lamina. Once you've done this, you place your working trocar, and then again you do a lateral X-ray shot to really make sure that it points, the center points towards the neuroforamen. Then you can insert your endoscope and you perform this procedure as you would do in microsurgical fashion. In this case, we don't do a P-view because you can do that, but the distance in the cervical spine from the mass lateral to the spinous process is very little. You can orientate more to the spinous process, and you will not end up lateral of that. In the lumbar spine, it's different, and the facet joint might be in your way. But if you are unsure, you can do an AP. We don't do that. And this is how it looks like once you inserted the endoscope. You can see here are the lamina. This is your interlaminar video right now. You will start drilling with a diamond burr. This is 3 millimeters. Again, you have an opening of about 5 millimeters right here. Once you see the ligamentum flavum, you remove it with a Carrison punch. And then this is your neuroforamen right here. You decompress this. This is the shoulder of the nerve root. This is the foramen. You decompress it as And with your blunt nerve hook, you always control if there is left. I hope that this video works. If not, oh yeah, perfect. So again, the quality is not as good as in real life because I have to render it down to get it up to 100 MB. This is the remnant muscle tissue. You have your dissector. You remove it till you touch the lamina. Here is the lamina. You have confirmed that your trocar is pointing, or the center of your trocar is pointing right to the nerve root. You don't have to worry about caudal, cranial, medial, lateral, because you know the nerve root must be somewhere here. This is medial, this is lateral. I think in this case, I don't know if it was a left or right. This is the head. Here's the head. Cranial, this is caudal, medial, lateral. So, and if there was some remnant muscle tissue in your way and you cannot look clearly into the foraminotomy, remove the remnant muscle tissue again. And nerve hook to mobilize the ligamentum flavum. And positioning of the patient is very, very important in these cases, because if the venous pressure is too high and you would open the vein, there might be significant bleeding. Excuse me. Inclination flexion. As I said, Mayfield clamp, inclinate flexion. Try to get it as high as possible above the heart level. And so this is a 2 millimeter Kerrison punch. You can see that the exiting nerve root, and if there is still too much bone in your way, use the drill down to get a flaw. Use the Kerrison again to free up this nerve root. Again, positioning of that trocar is these nerve roots here, they are so close to each other. If there is if you're 5 degrees off, another nerve root, right? This is absolutely the key. And this is your friend. Once you have the impression that everything is free anymore, you're done. But you have to be very aware of the bleeding in these cases, because so minimal. We had one patient who had a, yeah, over there, this is the exiting nerve root. Yeah, this is the dura nerve root. See this? Yeah, no, the head is left. I didn't know the case. Might be some bleeding. Don't be scared. Coagulation and all that stuff doesn't help sponge instead. And in the end, there should be no active bleeding, because 5 cc of blood is enough to compress this nerve root. You can see here. We had to do a revision surgery because he had a bleeding and pain and a paralysis. In revision surgery, we saw that it's a small blood clot. Yeah, but again, 5 to 10 cc's are enough for. So depending on the size of the cervical spine and the lordosis, you can decompress up to 3 levels with one skin incision. I previously showed. And this is you can see there is no atrophy of the muscle. And this is a patient with a 2-level decompression. So far, these are old numbers. We have done over 50 or 60 cases. I think the majority of them, a 1-level procedure. This is not a problem. 3 levels, this is very, then I think, time-consuming, but you can do that. And the age is 29 to 82 years of age. Actually, this was a patient with a fracture to snowboarding accident, and there was a little bony spur which compressed the nerve root from posteriorly, so an anterior approach wouldn't be successful. We just removed this slight piece of bone, and since 4.5 years, I think so far now, this patient is fine at follow-up, and there are no signs of instability. Yeah, again, 19 to 50 millimeter working trocar. There was no emergency stopping, no CSF leak so far, and revision surgery due to a bleeding. The results overall are very good, but patients with previous cervical spine surgery, they had a less success rate compared to patients who were operated on at the first time. It was about 75%, and without previous surgery, so far it was 95%, and this is a 3-year follow-up. All success rate 85%. Okay, thank you very much. No, if
question was if you do only symptomatic level or you do multiple level imaging.
Most of those patients, they have a clear radiculopathy depending on one nerve root, one dermatoma. But if we see that it's not crystal clear, we might do, or frequently we do an injection, a nerve root block, sometimes 2 nerve root blocks, and we have the impression, once we have the impression that the patient might be symptomatic due to 2 different nerve roots, we will decompress both of them before we do injection CT guided.
You had bilateral as well, decompression.
We have I think 4 bilateral cases, and those were patients, they had previous anterior cervical discectomy and fusion, but due to fusion the cage subsided, and then the neuroforamen on both sides was shut, and there were bony spurs all over, and they had bilateral radicular symptoms.
How do you know when to stop taking the facets? You don't destabilize them. When do you stop breaking?
You will feel when it's moving, but if you have to remove half of the medial facet, we do that. We will decompress as much as needed till the nerve root is free. But because there is all the muscles are there in place, they are not. There is not subperiosteal preparation, and we had no so far we had no case where we had to do a fusion later on.
Do you do transforaminal injections to confirm the level? In case, let's say, you have multi-level generation.
Yeah, CT guided.
You don't do it on your own like that?
We do it on our own, CT guided. We have an intraoperative CT. Yeah. Yeah. Huh?
Is it not very slow? Adding a CT guided to transforaminal injection, does it add more time to the procedure? Because let's say for me it's 20 minutes.
We do the injection 1 or 2 days prior to the procedure.
Okay.
At least it's not on the day of the procedure.
No, but my question is when you do transforaminal cervical injection.
Yeah.
Adding CT guided to that, will it increase the procedure timing?
The procedure time, the foraminal injection. We never did this actually. So, well, our protocol is if we are not sure if it's C5 or C6, we will inject this nerve root. If they will profit from C5 or C6 or both, we will decide which nerve root we will decompress, and the surgery will be a few days later. Does not come into play.
The actual procedure of injection with the
CT?
Yeah.
Less than 10 minutes.
Okay.
The patient is lying on the table. He gets a CT of 1 level. We will plan the injection in 10 minutes. 7 minutes maybe.
Just the CT?
No, everything. CT, injection, and out.
Okay. Good.
All the injections, we will not perform the surgery.
Patient that you operate on, first you tried epidural injection with steroids, and if they fail, you move up.
Move up. But most of those
But you do
patients,
the
they
one every
already
month.
had, before they come to our hospital, they already had conservative treatment and injections.
Yeah.
Because we do not have the records of those injections who were done in the private practice and their x-rays and their operative notes.
Because
That's why we do all these injections on our own, because even a radiologist in Germany, if they say I've injected the nerve root L4, that does not mean that they have injected the nerve root L4. We cannot trust this. We only trust our own injection.
I've been waiting to start doing cervical endoscopy, and I qualify most of the endoscopy, but I failed the injections. The best by far. So they respond to injection, most of them.
Yeah.
I mean, in a year, I had to send only out of everything.
And
the rate of response is.
Did they had a Seos foraminal stenosis, or did they had a disc herniation?
Well, the one that I sent to surgery, the herniations, but the foraminal stenosis, they all responded. I still wait for the right patient.
Our experience is our experience is different. Foraminal stenosis, they will not respond, and the disc herniation, they respond better. Because and again, we are very, very conservative with this indication, because we have operated 50 patients, and these are 50 patients in 6 years. And we have done probably 600 ACDFs in that time.
That I sent to surgery were fragments in the foramen, and they had a bit of a weakness. So I didn't want to.
The young patient, I can look at my computer if you want to see that. This young patient with a fracture, he had a weakness and numbness and everything as well, which would not be suitable because the fragment was sitting behind the nerve root. Right, so you could either do a fusion or you could just remove that little fragment. And I mean, it's a young boy now. He's 30 years of age. Since 4 to 5 years right now, he's fine. Yeah, just open the lamina, pull the fragment out, done. Pull the fragment out. I have a video. I can show you this if you would like to see.
Great.
Would you like to see or not?
Okay.
I want to see if I have the preoperative MRI. Well, yeah. Fine. Put this in. Okay. So you can see this is the fragment. It's very narrow, but the patient had a paralysis 2 to 3 out of 5. And anterior approach, I mean, you could do this, but it would be very intense to remove that fragment. And again, we decided and the approach, everything essentially is the same. You open it, and then you need that nerve hook to feel where the fragment is. Here, you see? This is the fragment. And another piece. Oh, no, it stopped. Why did it do that? So again, then if it's free, the procedure is done. Okay, and he's fine so far. And there was a huge discussion always, okay, what to do with patients with a facet fracture. I mean, this is a tiny fracture. Fine to do it this way. If the patient would have a complete blowout of the fracture, I would not consider doing this endoscopically. I would consider doing a posterior fixation, certainly. Okay. Okay.
Okay, so I have to talk to you today about approach to a patient with back pain, and it should be unspecific back pain. So it's, for me, I think it's a pretty tough task to do, because it's you have really a lot to say and not much to say. But let me start like that. So life is kyphotic. It's kyphotic event. We know that that's what happens with all of us. And initially we are kyphotic, then we have double S, and then again we turn back to the kyphosis. So why is that? Because of the degeneration, of course. Let's say a few words about the spine. It's a unique structure, really. 25 usually motion segments, which are comprised of intervertebral disc and matched joints, which give constant motion, but not only motion, but also resistance. So it's a contradictory functions, motion and resistance. Different shape in different segments. Perception provides balance, stability, provides mobility. So it's a very highly functioning structure. Because of that, suffers painful wear and tear and a lot of problems. This is what WHO from 2017 says, that at some point we'll need to meet a spinal specialist. So whoever is doing spine will have a lot of work. Significant number of people are complaining and suffering with spinal problems. Second reason for sick leave after the flu. So first, people are going home because they get sick because of flu. So if we have this big problem, obviously that will be very interesting to sort out the problem, to understand why. So it's really big interest from media, from lawyers. Spine, for example, is #1 reason for litigation in United Kingdom. One of the biggest private insurers, the indemnity insurer MDU, insuring private spine. So they said we are not spine. So it's a big problem because there is a lot of so having said that, I have to also mention that becoming more and more unrealistic they would like to be 80 and to still do whatever they were doing 20. So I quite often actually lastly say to my patients, sorry, I cannot make you back to your 20s. And they try to understand that. I had recently a patient that was chasing me to, he's 75, and he was chasing me to fuse him because he was not possible anymore to run 6 kilometers for less than 30 minutes. And I have presented that to, and they started laughing, like always started laughing, and they said, we have the same problem. So, so patients are becoming really pushy. They would like to do everything that they were doing, and that's not always possible. So, unfortunately, we still don't heal spine. We just treat it. We try to help. We try to keep our patients going. Let's go back to that slide. So, as I said, there is a lot of work for the spinal surgeons, a lot of spinal problems, and let's see what the statistic shows. Despite a lot of patients have back pain, they suffer from back pain. Usually that is a self-limiting pain. So if you wait a while, the majority, 50%, okay within 4 to 8 weeks. But unfortunately, at some point in the future, a big percentage will recur. You will have these patients coming back to see you. So you have to, however, if you decide to wait for this 4 or 8 weeks, exclude trauma, you have to exclude red flags or some chronic course that will probably not get better. Do that, then wait. And that could be winning strategy with unspecific back pain in the majority of the cases. Let's see, we have 3 types of back pain based on the duration of the symptoms. We have acute back pain up to 6 weeks, and that's the majority of the back pain, especially when we talk about degenerative spine. We have subacute back pain, which is up to 12 weeks, back pain. At least 60%, that's another statistic, at least 60% of the patients with acute pain will return to work within a month. Here we are going back to the wait and win, so that's the winning strategy. So you don't have any big concerns, in case you don't have red flags. If you have a patient with non-specific back pain, you just wait and see what will happen. And in the majority of the cases, you will win. So 90% of the patients will return within 3 months. So that even reinforces what we just said now. Specific back pain, they get better in case you are not worried about red flags, trauma, or some tumor. So the main goal, we have to do something for these patients. So especially if you wait and if they are not getting well. So you have to see later, which unfortunately is not always possible. You can see quite often multi-level degeneration patients, and you really are in big wonder what you have to do and where is exactly the anatomical generator of the problems that the patient has. We can do much, but sometimes we are failing and we still cannot help to our patients. But still, if you push yourself to do a proper history, to do a proper examination, you will be in better position. Key points of the history are very important to establish where is the current location of the pain. At the end of your interview, you really should be possible to put your finger point and say, yeah, is that the maximum pain? And the patient should say yes. You have to be possible to answer together with the patient these questions, And this will give you a lot of information. How long is the pain? Is it constant pain? Sorry, that's makes. What makes pain better or worse? And whether the pain changes with time. That will give you a lot of information, and that will clarify for you a lot of the problems that the patient has. For me, the examination starts with the first eye contact with the patient. Usually I go and call myself the patient that is waiting in the waiting area, and I observe the patient. I observe how the patient is sitting, how the patient coach. I observe how the patient is walking, because in the initial contact, the patient still is not overlaying different psycho and social covers to his symptoms. And I think that this first contact, and for me, this first contact is really important. I observe the patient from the first second that I get in contact with him. The patient, for me, should be examined standing, sitting, and in lying position. Because in these three positions, you will get more information about the nature, how the patient, what is the pain, for example. Is it mechanical pain? Is it non-mechanical? Is it radicular pain? Is it neurogenic, muscular, or even neoplastic pain? You can get that. Please include your sacroiliac joint in your examination. The statistics says that about 30% of your patients with non-specific back pain have sacroiliac joint problem. So that is, for me at least, and I believe that this should be like that. This should be included in your standard examination. The back pain patients should have their sacroiliac joint examined. Proper history taking and examination, for me, reduces the unnecessary. It's unnecessary often is misleading imaging, because if you go and image your patients, you inevitably will find something, and then you will be tempted to treat that, especially if your radiologist says, oh, there is compression here, or there is contact there. So we all encounter these reports from radiologists, which are in the nothing, and they are not supported by any clinical signs and symptoms, but they are there, they are recorded, and we are obliged to attend that. Avoid unnecessary investigations. Vomits. This is the victims of the modern imaging technology. We have a lot of this. Because as you can see, again, the statistics says that if you x-ray somebody who is 50, 65 years old, you will see sclerosis, you will see disc collapse, you will see spurs, you will see a lot of problems. However, this will not be supported by any clinical signs and symptoms. And even worse, if you go and do an MRI scan below 40, you see 15% will have major abnormality. And if you scan over 40, then this percentage will be 30. So it is really, I cannot quote the exact study, but there was a study that was done in Cambridge. They recruited 100 completely healthy and complaining of nothing students. And they MRI'd these students, and they found pathology there which is clinically silent and not significant. Again, avoid unnecessary investigations for your patients with non-specific back pain. But on the other hand, necessary, you have to do it. So you have to be aware that sometimes this attitude of, yeah, there is a lot of are having unnecessary back pain, unspecific back pain, might mislead you to miss important things, to miss red flags, trauma, or even tumors. So you have to be careful when you name a patient with back pain. It's a dangerous diagnosis. So Another page with another slide with statistics. A significant source of problems. About 5 up to 45 different studies. But a significant portion of chronic spinal pain is coming from facets. You see cadaveric studies, 100% joints over 60 are degenerative. So you can expect a lot to be coming from the facets. So unfortunately, we don't have a specific test that or confirm in 100% of the cases facet joint pathology. That's why usually we have to diagnose facet joint problem indirectly, based on examination, imaging, and facet joint injections. How it stands now, there is no gold standard to support facet joint, but the facet joint injections play a significant role, so you have to strongly consider doing facet joint injections in your everyday practice. And in general injections, and for me the injection will give me additional information in case of non-specific pain, in case of multi-level degeneration. That for me is very valuable investigation. Also, to see how the patient will behave while I'm injecting. And if the patient is crazy while you're doing injection, obviously it's going to be more crazy when you're operating. So don't operate these patients. The accepted standard of diagnosing facet mediated pain is steroid injections. So consider injections for your patients with non-specific pain. Like that, you also will do something for these patients and they will be helpful and they will be grateful, sorry. Two types of injections. You can have therapeutic injection, you can have diagnostic injection. Two approaches, intra-articular injections, where you can target directly the facet, or you can block the medial branch. You have to be careful where you are injecting. So if you have symptomatic level, if you have a level that is degenerated, you may consider to inject also the level above because of the abundant innervation of the facet. Because one of the branches is coming from the same level, but the other is coming from the level above. So more and more people actually are injecting the the degenerative level that they see on the imaging, but sometimes also the level above, in case you decide to do this procedure.
I'm sure the degenerative process is more generalized than so if you're injecting, how many facet joints would you be injecting, or you're just depending on the imaging scene? But I'm sure it's a generalized process, degenerative.
You know, we are talking now about a non-specific pain. So you are quite often that have multi-level. You're right. But sometimes you see that one of the levels is really collapsed. You see that the facet is gapping. Empty, so-called open facet sign. That obviously that will be the level that you will choose to inject. But in that case, I will inject also the level above, because the innervation is coming from the level above as well. Not sufficient for you to inject only that level, but you have to go and inject the nerve on the level above. But sometimes you're right, you just feel the force.
It's not very clear on the imaging. How many can you go? Do you go to S1 or?
Yeah,
how many do you do?
Don't remember injecting more than 3 levels. More than 3, I have not injected myself more than 3 levels. No, just one go. I do 3-level injections. but I don't do more because the timing, you inject a lot, patient is becoming nervous, and obviously the usage of the steroids that you're using and the is surpassing the safe dosage. So I don't go over 3 levels. For me, 6 joints is the maximum that I can do.
Yeah, but
yes.
normally the painful are the lower ones.
Sorry, I don't hear.
Radiological elevation of the facet, you rely more on the X-ray simply, or you go for the CT as well?
So I do MRI scan. I usually don't do CT scan. I'm suspecting, let's say, pars defect or something like that. What I do, however, in the majority of my patients is standing X-rays. I do dynamic X-rays, and on that dynamic X-rays, you can see instability, which you cannot see on the MRI scan. And if you see instability, obviously that's your symptomatic level.
By instability, you mean body listhesis or some facet instability?
I mean by instability, more than 4 millimeter movement of the body, the more than 11-degree angulation.
Like, doesn't it further aid to the confusion that this pain is arising from the disc space rather than from the facet?
Disc space,
Like, there is
pain,
listhesis.
disc pain is something that is confirmed. So there is people that believe on the discogenic pain. There is people that don't believe in that, because you see a lot of patients which have disc pathology and they're perfectly okay, and then you see patients that have this disc pathology and they are not okay, they are complaining and they don't have anything else. So some people are accepting the disc as a pain generator, and probably there is a role from that. At the minute, there is no firm data that will support one or the other statement. We don't know. That's the short answer.
But to answer your question, this is the point of the block. So if
Yes.
you think it's from the disc, you numb up the facet
Exactly.
and you see if it's pain left. The
So-
important thing with the facet is if you do the nerve block, you need to do always 2 nerves for a facet and always inject small volumes. 1 ml of lidocaine on the Luschka nerve is going to leak for sure in the foramen
Yes.
and gets the exiting nerve root enough to take the pain away, and you have a positive block, but you don't have a diagnosis. 2.3 ml of local anesthetic, and you need to give a certain, you choose your lidocaine or whatever, and then you try to find out if the patient has pain relief for an hour, 2 hours, or 3 hours. It should be 2 hours. If you lidocaine and they tell you I've been pain-free till next week, it's placebo.
Like saying that, you mean you do not give blood to multiple level at a time.
You do give multiple levels, but you give 0.3, 0.3, 0.3 on the Luschka nerve.
No,
So-
like if you give, like, for example, 3-level block, you never know that this particular block was the culprit. Like, you give it in that particular case, how do you know that this particular facet was responsible for the pain?
Oh, I see your point. If you do RF on two joints or 3, it makes no difference. So in terms of the risk, there's no point to do, let's say, radiofrequency ablation of 1 facet. There's never one level disease. So if you do 2 joints, it's fine.
Yeah.
We routinely do three nerves RF on both sides. See how the patient does, and if it's not better, then you move up. But most of the pathology is obviously L5S1, L4, L5. That's where
So
it's most-
I will show you in a short while a picture why that is so. Why we have to do at least 2.
I know that.
Because
Why do
one
we
of the
have-
nerve
we
is
have
coming
two
from
nerve
above.
branches. Yeah,
Exactly.
yeah.
Yeah. So the short answer is still there is a lot of unknown in that area, but that's what we do at the minute. I personally, if I see multi-level degeneration, and in case let's say if I see a listhesis and I am planning to operate that, I will go and do bilateral facet joint, a nerve root. So like that, I will completely block the whole level, and then I'll see how the patient feels. If the patient has significant improvement, let's say if the patient has like 80% improvement of his symptoms, then I go and talk to him, and then I offer surgery. But if that's not the case, then obviously that's not the symptomatic level, or that's not the only. So you have to continue to search. Sometimes at the end of the day, I offer to the patient also SPECT. I can show you a picture of that as well to see how, for example, exposed very nicely the sacroiliac joint in one patient. You see that I'll show you a picture in a second. More or less, I basically will conclude that the facet joints, in case you are treating the patient with the facet joint injections, you should never leave the facet joint injection as a standalone procedure. That should be followed by different procedures, by rehabilitation, very intensive physiotherapy. You have to accept that as a window of opportunity for your patients to go back in track. Right, so basically it is, in the majority of the guidelines show that you have a patient with unspecific back pain, you take good examination, flags, just discontinue. And then 90% of the patients will settle. It continues for after like 4 to 6 weeks. You then have to obtain the X-ray or your imaging, and then you have to treat the patient based on what you will find on that imaging. So in short, that is what all the guidelines will advise you in a situation with non-specific pain. So for me, message that I would like to pass to you is the back pain is incidence, but about 90% will settle down within 4 to 6 weeks. Cautious to not overreact and as being non-specific back pain before you're sure that you're not missing that. You have to reevaluate the patient within 4 to 6 weeks to see if that has settled or you need to do more. In case that has not settled, you have to obtain your imaging, you have to obtain your laboratory. You have to the specific pain generator based on all that you have done for the patient, and you have to treat that respectively. You have to include the sacroiliac joint in your battery of evaluating your. Thank you. So let's say if patient has, obviously that for me is a red flag that I have to continue to investigate. If I see that the patient has weakness, not leave the patient without me further and investigating and digging deeper to see where is that weakness coming from. Or let's say if the patient has problems with controlling bowel and bladder, that's another huge red flag for me. That is not just back pain, should be further investigated. Sorry?
That means the patient with a deficit.
Yes. For example, if you see a pattern of the pain that is not chronic low back pain, for example, you see a patient that is not typical mechanical back pain, but the pain is, let's say, increasing during night and it's settling down over the day. So this could be neoplastic pain, for example. So I will be having thoughts where I have to go and investigate that patient.
Okay, thank you.
I grew up in a communist country, so for me the cowboys were the cool guys. So I love Western movies. So I'll try to wrap it up, but this is late already and everybody's tired. But endoscopy is picking up, and we need to edit together what's good and bad and what we should not do. And I think still happening, and Honor does a great job. But ideally, even a Jedi sword is getting too long nowadays. So we need to get as minimal as possible, and if it doesn't work, we escalate. Yeah, well, we have different pictures here that we can play with, but I want to go back to this slide. Remember, this is mail, and this is Facebook, and this is where we should be. On this curve, we need to stay ahead of the curve if you want to be with what's happening. And yesterday, we had a revision discussing a case with the team, and there were different opinions. And I want to draw your attention on this study done on Northern American Spine Association, where they had 24 surgeons doing just spine. So they were doing literally orthopods and neurosurgeons just spine. The average practice experience was 13 years, and they were given 6 clinical vignettes, clinical scenarios with all the X-rays, MRIs, and CT scan, and they're offered options A, B, C, D, F, and choose what they want to do. So interesting enough, out of the 6 vignettes, 13 years of practice, on only one vignette, they all agreed not to operate. On only one, they all agreed to operate, but never which kind. They all offer different procedures. On the other 4 vignettes, they could not agree, operate or not, and on the interventions. This is Northern American Spine Association, so it's a big study. More interesting, 6 months later, they were given the same vignettes and asked, what do you do now? So interesting enough, same surgeon never picked up the same option on the patient. So even you against yourself, you cannot agree on your decision. Well, I can tell you, Germans are perfect and the rest of the world is different. But I can tell you, even me, when I do my injections and my interventions, I schedule something and I go back and I look at the MRI, the patient changes his story. I said, I think it's not that level, let's do another one. So we are practicing in very murky waters and we're confused, but this is the truth. We against ourselves, we never pick the same alternative, So my approach is basically, I don't care how big the hernia is, and I only go by the symptoms. Depends how long the symptoms are and how severe they are. If they have severe symptoms, short duration, there's no indication. I'm talking pain here. If they have mediocre pain long term, there's no indication. I never escalate. So literally, I never go by the same. If the symptoms if the pain is uncontrollable, endoscopy. If it's new motor deficit or a volume 1, then you have to escalate. Because in Romania, many people get convinced that they're numb and they should have surgery. And I tell them, if you get in the an endoscopy for that, the numbness will be there for a while. The old deficit we don't operate on if they're stable, and if they're moderate, we just put them into rehab, and in a month or 2, they all recover. They come after a month of 3 out of 5 strength, we just put them into rehab. They do very well.
What is no place?
More than a month.
More than a month?
Yeah, 3 months. More than 3.
More than 3.
Yeah.
So even that, you see.
So 1, 2, 3.
Yeah. So we don't escalate. This is a video, a picture of how it was before and after. We don't normally check MRIs afterwards, but I'll show you some pictures when we start doing that. Part as a surgeon, when you start doing this procedure, you need to have a team approach. And anybody in this team is critical because you're stepping in different. For example, when you travel, the X-ray technician is critical. If the C-arm changes the angulation, they move it around, you focus on the patient and you assume that the operator know what he's doing, and everything gets a disaster. So X-ray technician is critical, anesthesia is very important, and we're going to go over that why. So why is anesthesia important? Because you need to have, at least in my hands, I do the patient awake with a bit of sedation. It's important that the anesthesiologist and the surgeon explains the patient what to expect. Because if the patient expects to be totally pain-free and out, then you're going to have a very agitated patient and very, very uncomfortable moving all the time. But we use all the time dormicum is midazolam, and then fentanyl. You need a bit of amnesia, and a bit of analgesia. Once you place your local anesthesia, they don't need anything else. We did 2 cases 2 days ago, and we have another one tomorrow, which is 70-year-old diabetic with heart failure, indication for surgery, huge hernia that we have to do tomorrow. So nobody wants to give him anesthesia. All these cases with the difficult anesthetic patients. But a knocked out patient is dangerous. Why? Because you can damage structures. Your field of view is very narrow, and if the patient talks back to you, you need to know. Well informed beforehand, this is for your safety. It's not going to be painful, but it's a bit of discomfort. It's very easy to do that. If the patient has different expectations, then they're going to move over the place. They're going to get very, very agitated. And if you do it right, it should never be painful. I think, if the patient is well informed, the local anesthesia is the next thing. And the only part that hurts is the skin. Then, you talk to the patient first before you do stuff. We used to poke and then tell them, does it hurt? No, it's the other way around. Be some pain, and then you touch the patient. Because he expects, he's relaxed, and then he expects he's going to have some pain. Otherwise, he's going to stay tense and not sure what's going to be next.
A lot of people in Germany, for example, that procedure with general anesthesia. I have, Ralph Wagner.
Mm-hmm.
Yeah, so he's been on the journey.
But you see what happens once you become Ralph? It's okay to knock them in the head, because it doesn't matter, he's done 1,000, right? Your first 20, 30 cases and you're alone, there's no Ralph behind you to say, stop, don't do this, don't do that. And I got trained by another orthopath from Germany, Michael Hess, and all his patients are awake. He's done 1,000 plus too. So it's a matter of, in the end, of course, if you know what you're doing, you want the patient to shut up, because they talk a lot. And they tell you your life stories, and they tell you about their problems, and you're like, because I need to focus here, and they get very disinhibited from the dormicum, from the midazolam, and they talk too much sometimes. So it is a problem. You like them to be knocked out. Well, somebody used to say,
Is that men or women that
depends. So once you do the skin, you need to hook up your anesthetic to the needle, and as you go towards the facet, because if you don't, if the patient is sedated with propofol, when you dilate and then you put the trocars, they will move like crazy without local anesthetic. They will never stay still. And the next spot is the facet. If you touch the right spot and you inject the facet with 5 ml of anesthetic, so when you drill and go inside the canal, there's no pain. So these are the main pain generators that if you put the local, the rest of the intervention is just pressure. When you dilate and you drill at the 5S1, you tell them ahead, you may feel some pain in the hip area. It's okay, let me know if it's going down your leg. But other than that, there's no need to overshoot giving anesthetic, because the point is you want feedback, especially when you are alone, because with the guys that are experienced, you're comfortable because you know where you are. The X-ray doesn't go right anymore because he changes angles. Complaining of pain, he gets propofol from the anesthesiologist, because anesthesia wants to put them to sleep always. And next thing, he's disinhibited, he's getting confused in a twilight zone, not deep anesthesia, not shallow. He doesn't follow any more commands. You touch him, he moves again. Ugh. Stop moving. More propofol. You touch him, he moves again. So this becomes a nightmare. So either you keep them awake, or you're like Ralph Wagner, put them out, intubate them, and whatever happens, happens. But if you do them safely, there's no reason to worry about that. Of course, in very sick patient population, this is perfect. Why? Because they hurt, they're afraid of general anesthesia, and they will assume there's going to be some discomfort. So they're like the guy tomorrow, I told him he'd be awake, he'd be a bit, local anesthesia. I said, fine. He's been in pain for 3 weeks. He has a huge hernia, actually. Positioning on the OR table is very important. In the initial cases, you're going to spend 2 hours with the intervention, 2 hours and a half. You mark with the needle around and you're not sure where you are, so it takes time. You got to make sure that the patient is comfortable. If it's women, make sure that the breasts are free. Try to have the belly hanging free, because otherwise it's increased abdominal pressure, bleeding, and have pads around. But it's important that for 2 hours, the patient sits on the table comfortable. He can move his head. He can move his arm. It's okay. Because otherwise, after 2 hours, you need somebody to move his head. I insist on the technician because there's so much information in your first 20 cases, 30 cases on your own, everything. So you should always be with the same OR technician and with the same anesthesiologist.
because I'm an anesthesiologist, I never call anesthesia. I do the cases alone with my assistant. For 3 years, we did only the two of us. And so stuff that helping is like you just sit and watch. But 2 people was enough to do the whole case. The important thing, and we practice this 2 days, but if it's something to take home, make sure that you have parallel end plates when you look at the level. Parallel, you have wrong needle placement, wrong position, and then all the badness happen. You need to have the end plates parallel. I forgot who, but basically from the parallel, they need to be AP and lateral. Have a good AP line up, but when you go lateral, depending on the patient kyphosis, it may not line up as well. The C-arm technician, plays with the C-arm so you get perfect lateral view as well. Don't be afraid to go AP and lateral and take as many X-rays as you need initially. We talked about, X-ray safety. If you put the X-ray machine in pulse dose in pediatric, the dose is dismal. Literally, it's not even worth like half a chest X-ray for you. Talk to the patient first. There's something that we always forget, especially as surgeons. You want the patient knocked out and not talk to them. But if you tell them, you will feel this, and then you do, patient is nice and calm. If you don't tell them and you start reaming, no pain, but they start moving because they're too tensed. You detense by communication. That's something that we're not very used to. It's low cost. Obviously, you don't have to admit them. They're all outpatient. It takes, once you get comfortable, like you were saying, all the minimal invasive is longer initially. But once you're comfortable, an hour and a half at most, from skin to skin at most. The big hernias, 35 minutes, 40 minutes. The bigger, the better they are. You don't need to put them to sleep again. It's outpatient. It makes a huge patient satisfaction because all these guys know the stories from the internet, how the patients do afterwards. And they read how difficult it was with the anesthesia, how they were throwing up, and how they were in bed for 2 days, 4 days, and so forth. And they walk next day without any problem. I'm not sure if you like cowboys in Pakistan, but I was in love with them. The thing that I also learned is that you don't need to clean everything out. And most likely in the initial cases, you're not perfectly placed. But if you decompress the nerve root and is moving freely, hernia has a natural evolution. Disappear, maybe going to be 2-3 years before it goes away. There's no pain. You don't destabilize. So the fact that you don't touch the flavum, you don't touch the paravertebral muscles, there's no post-op denervation. The patient is left intact. You only trim a bit of the SAP on the L5-S1 for the outside-in technique, which is, I think, is the best. For 4-5-3-4, you don't need to trim anything. A little bit further in, and there's so much soft tissue in the facet that you just go in the canal without doing any drilling. There's no failback because you don't cause any scar tissue in the spinal canal. And there's no discardis because you irrigate all the time. And I told you I even put antibiotic in the irrigation to be on the safe side. The bad thing is, about endoscopy is that there's a certain step that you cannot miss, especially in the first cases. If you remember, there was a Tom Sheedy needle on the X-ray, a sharp diamond tip that you were hammering in. That needs to be for sure your final position. It's like having those trivia questions. Is this your final answer? So you got to make sure that your tip sits in the right position, because once you hammer it, anymore. And then if you land up in the wrong place in the canal, not that you damage anything, but the hernia can be a centimeter away and you cannot see anything. And if you see it, because you use the methylene blue, you cannot reach it because the instruments right now don't really go around the curve. There's more coming up, but for now you can only work within a 2-3 millimeter window. You have to be very safe. If it's really that bad, as you advance, you will learn how to reposition. But most of the time when you try to reposition, you slip in the same canal. You go in the same hole that you created initially. There are certain traps that you need to look after the large facets, because when you start hammering and drilling, if it's a big facet and it's super bony, you're going to start getting nervous. You have to ask the nurse to hold counter pressure to be able to go through, and you start hesitating. Part is that your first cases go well, because if something goes wrong, you'll never start again. You could distract me anytime you want. Versus me, I had no choice. I had to keep going forward. So it's a solution. The other thing you need to look for, it's a narrow foramen. It's dropped, and then you have facet hypertrophy. You see the hernia on the MRI, but to reach there is really tight. So drilling through a narrow foramen is not easy, and it makes you really, really uncomfortable in the first cases. The best cases to start with is usually a 4 or 5 healthier big discs, So it's difficult for the surgeon because you guys always come from the top and you expect a certain anatomy, and this is totally different. And in the workshop, and even today, people are asking, where is the nerve? Where is the disc? Some of the orthopaths do the endoscopy on the side, and everything is in the mirror. So they put even the camera the other way, they turn, so you go that way on the endoscopy, but actually you're in the other corner. To this 3D view, it's a bit different. And you kind of get lost initially. So the learning curve, it took me about 10 or 12 patients done with a proctor, and then after that, what else? You need to have a 3D view, and that's something that you acquire with cases. You look at the X-ray and you can always point out, this is the pedicle, this is the facet, this is this and that. But when you have to go AP lateral and see where you are getting confused. And this 3D guide, it is difficult. Of course, now there's navigation coming up and so forth. They can afford in Germany, but not in Romania and in Pakistan, and we have to manage with what we have. So it's a bit more difficult. But I think navigation is going to become very feasible in the next few years, and then it's going to pick up a lot. It takes patience in the beginning in proctoring, and the problem, I think, is perceived too much for the non-surgical specialties and too little for the surgical specialties. And that's why it takes so long to pick up. There's one fact is that the complexity that is too much for some, too little for others. The other one, it's the approach to the patient needs to be different. Sedation, talking to them, and the surgeons don't like to talk to their patients by nature. So I say slower learning curve. Some people say steep learning curve. When you say steep, it means that you get there quick. This is slow. It takes you forever to actually get to what you expect. Why? Because your expectations are wrong. You think you come to a workshop or two, and then you can do endoscopy. It took you years to learn microdiscectomy, to do it right. You cannot expect to come to workshop and next thing you actually do it home. So that's why, set up your expectation well. But thanks God, because that's why you can really be the special guy in your community who does endoscopy, and it's not for everybody. It's one thing to go for the workshop and practice. It's something else to do this at home alone. And sometimes you have the father of the prime minister, like tomorrow, whatever senator the patient is. So it's even more stressed that you deal with it. So it takes a while to be comfortable to tell who is doing this. So there's not much ugly about it. The only thing that can really go wrong is moving. So if he's awake and communicative, if he moves is something really bad, then you should tell anesthesia, don't put him to sleep, put back the trocars and reassess. But if he's sedated and you create pain, then it's a nightmare because you can be in the right place, but all the landmarks are changing and you're just all over the place and you have no idea what's next. And if he just says, stop, I need to give more propofol, and you're like, I don't know where I am, abort. Tomorrow you can call him back and do a microdiscectomy, but your enthusiasm is going to go down. So I think restless patient should be, if it's an awake patient, something wrong and it's fine. Either you've done the wrong anesthesia, local anesthesia placement, or you're in the wrong place. Do not be there just to pat his head and don't touch propofol, at least for your first cases, unless you have an experienced guy with you all the time. I managed, because I can't sleep since I got here. So last night I went at 3:30 to bed. I pulled a lot of pictures with this patient, but this is with different patients. But that's how you usually assess pre-op. So we do, even though the patient is supine in the MRI, you measure the distance to get a guideline. As I told everybody, more important is actually the angle. So your angle is about 30 degrees, but you have to keep in mind there's a lordosis. 29, 30 degrees, the approach changes. As you go into the lordosis, you're almost flat with the floor. You saw today on the cadaver that we were at the L4 and 5 parallel to the actual floor. But we're in the right place. So you need to think 3D, and it takes. This is actually my cousin that we took out one of the biggest hernia that I had. And I had a visiting orthopath from Chicago, and he came from Transylvania to visit me with my uncle, actually. Pain a week ago, but now I just have a little bit on the leg. So, indication for an MRI, but because he's my cousin, not to have bad words, hernia. So very little symptoms, orthopod, and the orthopod said, you know, I would not send him home because if he coughs, his pants. Yeah, we put the methylene blue. We put methylene blue in the disc because it helps you with orientation. My first 2 years, I didn't have it, and you pray for God when you pull the first time out because you're not sure what you're pulling on. But this is one video. There were 3 more fragments like this that actually came out. The 8 centimeter disc that we took out was a huge sequester. So this was 3 pieces that came out one after another. It was 35 minutes case. Was the shortest I've ever done. This is a patient that is, look at how fat she is. She's about 150 centimeters, 140 pounds. She came with a huge hernia in the foramen in May. She could barely stand on the table. The C-arm could not go lateral. You couldn't see because how fat she was. You couldn't get any landmarks. So I just went by AP, where I think I am. We took out the foraminal hernia. She was fine for 5 months. Hernia this time she's all cranially migrated, and you can see it here on the left side, severe pain suddenly. So this is when they reherniate. Now we start doing the MRI afterwards to make sure that we take everything out and there's no talks afterwards. So this was the MRI afterwards. There's a bit of a fragment left here, left there. She has diabetes, all the problems, 70-year-old. She's a former national champion of tennis in Romania. How can you be a national champion and wind up like that? I have no idea. But, you know, that's what life takes you. Fake ID. Literally, she was national tennis. I mean, look at all the paravertebral muscles, the electrospine and everything, how she looks like. This is a patient that actually is changing my practice because he came to us with no pain, quad hypertrophy, and he had this EMG, which was done like a week before with severe loss of myelin. And unfortunately, I don't have his MRI before the procedure. So, look at this landmark here. What do you think this is? Sorry? That's what I thought. You should have seen the pre-op MRI where there was a huge extraforaminal hernia here. This is actually the swollen nerve. Coronal, look at the nerve here. If you look at the root, no, it's a very swollen, you know, exiting nerve root. So basically, this is just the nerve. If you compare the densities, they're similar, but this is swollen. And this is afterwards, you know, how it was decompressed. And this is on the sagittal one, this is a nerve here. Here, this is the swollen nerve. So this was difficult because it's extraforaminal. The nerve is pushed into your face. It wasn't that big. And take it out and never recover. He's doing very well with rehab now. But again, according to my criteria, he had no indication because he was all deficit. This is the most horrible EMG I've ever seen. He's going to lose that nerve completely. What's this one? This is another herniation that we had, and this is the MRI. We took it out before and after a month. No, after 2 weeks, she comes with a new herniation that is moved caudally, and you can see it how it's here, you know. Well, and this is the post-op one immediately. Now we do, as I said, you know, MRIs after each herniation to document that we take stuff out, and you can see the approach. This is where the trocar went in. You see, because you dilate the facet, and this is all the soft tissue being pushed away, and this is the immediate post-op track. And this is just the water into the disc, and there's no fragment left after that if you look on the sagittal one. This is a young patient. She's an anesthesiologist. She's a neonatologist, and the husband is an anesthesiologist, old, also obese. So of course you can argue, should we do fixation, this and that? She's been like this for a year, taking night calls and everything, depending on what they want to do. This was last week. I almost went nuts. So this is a patient that came with a huge herniation, took out a lot of big fragments, and afterwards he had a dry foot. It happens sometimes when injecting the facet, if you give a lot of volume, that the anesthetic leaks out, and they may get some deficit, which makes it dangerous because you lose your feedback from the patient. You wait for an hour or two. He still had a dry foot, so we took it to the MRI. This was the pre-op, I mean, the post-intervention MRI. We cursed a lot in Romania, so I cursed. I said, shit, I have to take it back to the operating room. There's a hernia there. This is the intra-op where I was, in the canal. This is the grasper behind the pedicle here. This is the pedicle, and I'm not in the disc. I'm outside the disc. Hernia. There was none. So I said, what's wrong with it? Something that doesn't make sense. That doesn't add up. And if you look here, actually, this is one. There's the protrusion. And when you go in the disc and you take stuff out, this is the water after the intervention. So eventually it shrinks out and it decompresses. It was just the defect from having a big fragment for 2 months there, pushing the dura away. So I went back in right afterwards for no good reason, but now I learned my lesson. And I talked to the neurosurgeon, and he says, the same thing happened to me, now I understand why. Similar patient that he went for microdiscectomy, the post-op patient had pain afterwards. The fragment was there and he couldn't find it. So that's something for you to remember. If you see this, don't get tricked, this is leftover hernia. Because if you look at the initial MRI, there was density with the disc, and this is just the defect from the, it goes away. This one? No, pain. Well, the foot drop was from anesthetic. Because by the time we did the MRI, the foot drop was gone. So I said, no, I reiterated, it was immediately for the MRI. But once I saw the defect, I said, he has no defect, he's totally pain-free, but I cannot leave the hernia there and send him home. So then I went back in for no reason. So that one was a reintervention for no good reason. I just got scared and the deficit went away. See what it is? Will I see it? What is this? Take a guess. That's a nerve root, yeah. It's a dural tear. This is my first documented dural tear because I couldn't make anything out of it. I think after this one that I actually had 2. But the reason why I think it's a dural tear is because the nerve is popping your face. So, I put on the disc, they were likely, maybe I grabbed a little bit of the dura and I didn't see it. That's the blues from the disc, from the endoscopy, from the methylene blue. Never pop in your face like that. And if you look further inside, the root's there. But basically, the CSF pressure is pushing it in your face because your irrigation runs out and there's no pressure in the system. Just the CSF pressure is pushing it in your face, and you don't see the CSF because you irrigate a lot. So what do you do with them? Nothing. It's pinpoint, and what happens is that you don't have a vitreal cavity. When you do microdiscectomy and you get a dural tear, and nothing can seal it, right? With this ones, because it's ventrolateral dural tear and there's no vitreal space. So I told that we documented and told the patient there's a dural tear, lie in bed for 3 days and don't, drink as much caffeine, never had the problem. Endoscopy there, you almost never touch them. No, there are reports where you could take a muscle, like a muscle punch. You can do a muscle punch from the soft tissues and put it there with some fibrin glue, but there's no reason to because it's a small tear. I'm not running very sure. This one is just a very good anatomy of. This is the patient that actually I took out the fragment on the reherniation, the exiting nerve root here, and this is the dura further. You can. I'm gonna slide the. You see, this is the exiting. The traversing nerve. Dura there. So you see how I go in between. This is the dura, and this is the traversing nerve. This is medial here now. I always get these difficult cases because nobody wants to touch them. But this patient had cardiac pacers. That's why we only have a CT scan, and the MRI was old. Hernia. Thinking I have a big herniation, and I was comfortable. This is just a hernia. It was all bone. And if I try to replay that, the air is from the trocar in there. There it goes. I'll try to show you where you actually position like this. There you go. So this is how you actually get in. You see the facet, this is L5S1. So you remove the distal end of the facet. This is the air from the former approach that we took out, and actually I killed the grasper because of that, because they're not meant to take out bones. So outpatient procedure locals, we talked about that. I managed last night to get some reports on our data actually. You're the first one to see this actually. I only saw it this morning, so they may. So we've done about 126 patients in these 3 years plus. They had 131 interventions, and 2 of them became open discectomy. So in the 26 patients, there were 8 reinterventions, 6%. 6 were endoscopically reintervented, and the other 2 were open discectomy. We offer the patients to choose if they want to go for the intervention open versus endoscopic. So in the 126 patients, if you divide them, we had 24 discectomies that reherniated. So 90% of them were actually former herniations that came for a new herniation. We have 72% new de novo herniations, and we did foraminoplasty, which we just started in the last time for 19 patients, for 11 patients. But most likely, it's of interest for everybody. The patient that already had the open discectomies, 16% reherniated. So the rate of reherniation after the open endoscopy is higher. So of course there could be an argument: should we fuse them from the beginning? And with the surgeons, and the patient refuses routinely to go for the big cases. For the de novo, for the new endoscopic interventions, we have a 4% recurrence rate, and the average follow-up, it's about, it varies months at this point because of the statistics. Most of the interventions, so there is a misconception that you cannot do a 5S1 endoscopy. Most of them are 5S1, 4%. I did only 1 or 2 very high ones. The 1 or 2 and 2, 3, they respond to injections very well. Rarely you need to do something. And they're more difficult. They have more complications, but these were huge hernias, both of them. This is less important, but all of them had, clinical exam modification. Initially, the first 2 years, I never touched motor deficits because I wasn't very comfortable. So I said, if you have a big deficit, go see the surgeon. And now we do motor deficits severe routinely. We don't even, they're difficult because most of them are in the foramen, and it's hard to get there because it's hard to position them. They do well. EMG we use very rarely, almost never, but I think I use it more often now after this patient that came with a very modified EMG. I think it's just blah, blah, blah. This is, yeah. A lot of them are big hernias, so not so much smaller ones, is big protrusions and migrations. And we say the bigger the hernia, the better they do, because the hernia is protecting you. Stuff. This is their pathology. There should be one. In the end, regarding complications, we had but never were symptomatic. We never had any bleeding, never had any hematoma, never had any infection. We talked about this. The leak was only the one that I showed you the MRI, the video, which were the foraminoplasties. So 0 complications. Success rate is not as good though. Plasty on the failed back, severe failed backs that failed even spinal cord stimulator, didn't help them at all. They had severe spinal stenosis. In Romania, a lot of the patients are underfused. There's very few hardware patients. Most of them are open discectomies and have a degree of instability and refuse surgery. I was telling everybody I had a drop foot on my last proctoring patient. So the last proctoring patient has a total foot drop with a visiting doctor from Germany. We had to open him that night. The doctor left, and I decided, the doctor said, let's be conservative and see how she recovers. But we decided to go back and take everything out. She had no problem. She had total recovery of the deficit. And I got to start doing on my own endoscopy after we had a full foot drop. It wasn't that easy. And other than that, it's pretty straightforward. But good. For the first hernia, the pain status, the NRS is dropped significantly. It's a bit more complicated because they always ask about the back pain. And I tell them, if you want back pain, you need a fusion, but if it's leg pain dominant, we can take care of that. And none of these reherniations after open discectomy, none of them is fused up to date. I had to re-intervene twice because he re-herniated and he kept refusing surgery of local culture. In terms of McNabb score, the foraminoplasty, 20% poor, and again, it's patient selection, but these were severe failed back patients, many surgeries, both of them. And I think that's the average follow-up. It's dynamic because it goes up to the last 6 months. Thank you.
I think we just wrap up here. Sorry, just maybe one question. Anybody, one question? Everybody's tired. No, I'd like to really thank everybody who's come here, and it's been wonderful. We have learned a lot. I would request any of the participants, if they want to come and say a few words. Anwar, whatever, whoever. One of you can come and say whatever you've learned and was good, bad, or ugly.
Me as Dr. Nader Hussain from Faisalabad. It was an excellent workshop, and there was expertise from the foreign delegate, very expert, and particularly they could communicate well, and we learned a lot of things. And this workshop is important in this aspect that the topics were different and they were advanced. We are very thankful for the organizer and particularly Professor Salman Saab, and they arranged this workshop very well. Well, thank you very much. Thank you.
Nicola, you haven't said a word, so maybe you can come and say a few words. Yeah. Owner is sleeping as well, so maybe he gets a chance.
Okay. Right. Okay, so it's my third time coming here. So every time I'm coming here, I'm always enjoying meeting enthusiastic, having now good friends. So I hope that our presence here and sorry for my late presence, but still, I hope that it is useful for you, and it's useful always for me to discuss, because when you learn, you teach, and then so I hope it had been like that for you as well. Two-way process, learning and teaching, and you enjoy it as much as I have enjoyed.
I'm very thankful to you.
Come, you want to come here?
No, otherwise he won't go.
Yeah. Like since 2011,
very good.
in this workshop, it was very hard. We learned a lot, but like putting two pain management as well as minimal spine, it's both are so big thing. Like at time it becomes difficult to learn both.
One is the same thing, because the idea is the same.
Yeah. I think next time if you can have this kind of workshop, it should be separate ones, so that we are more focused on one area.
I'm not sure. It's good, but I think the MIS works exactly like how we inject. So that's why, because it's the same philosophy, it's the same thinking. If you're good at injection,
It's the same one absolutely.
We are
I think we learned a lot from your questions.
owner, would you like to come and say a few words at this stage? We'll get Mehmet to close this up. Mehmet, can you come and please close this?
I think, as always, I thank all the participants, the faculty, all the organizers, flag they got from me, and some of my residents who are operating today. I apologize that you couldn't be here. But they had the choice either to go to the boat or miss this. They missed this and they want to go to the boat. So it's their choice. Sorry? They were operating. They voted to operate while the workshop was going on, and so that they can be on the boat this evening. So that's their choice. And wise, yeah, I agree. Okay, so let's close this. Thank you very much. And inshallah, if God willing, if all will be fine, then hopefully we'll see you for skull-based meeting soon in February 15, 16, 17. Okay, thank you.